Good evening. We have a much constricted audience now. Many people probably are exhausted at this time. But nevertheless, it's an important one because we are going to discuss the importance of public health leadership and data-driven decision-making. And it's my pleasure to introduce to you the panelists on this particular session today. I will start with those who are present here in the auditorium. It's my pleasure to introduce Dr. Ajoy Chakraborty, and as I am introducing them, I'm requesting them to please come on the dais. So Dr. Ajoy Chakraborty has been introduced earlier. He is the Director of Health Services currently and works for the government of West Bengal. He is the MAE Scholar of National Institute of Epidemiology, and starting from the block level as a medical officer, he has risen to this particular rank as of now. And walking through multiple assignments has been CMOH of 2 high priority districts and then state immunization officer as well as state RCH officer. Welcome, Dr. Chakraborty. I then introduce Dr. Puran Kumar Sharma, who is with us, again a MAE graduate of National Institute of Epidemiology, and currently he is the Chief Medical Officer of Health at Alipurduar in West Bengal. Has a lot of experience in with respect to outbreak investigations of diverse in nature, dengue, Japanese encephalitis, malaria, and so on and so forth. He has also published extensively. Welcome, Dr. Sharma. Then I'll introduce to you Dr. Madan Mohan Pradhan. Again, he has been introduced earlier because he was on the earlier panel as well. Dr. Pradhan was the FETP MAE graduate of NIE in 2004 and particularly recognized for his contribution in development of Odisha multi-disease surveillance system, and more interestingly, his work with malaria, which and the Daman program, which was earlier referred to, and we are going to discuss some of these programs during the session today, and how these could be important in the national context. And lastly, here I would like to introduce Dr. Vidhya Viswanathan. She probably is the youngest among all the other graduates who are sitting here on the dais. Welcome, Dr. Vidhya. She started as a medical officer in a rural primary health center and now currently works in the Directorate of Public Health and Preventive Medicine, Tamil Nadu, focusing specifically on the work related to non-communicable diseases. And we are going to ask her about the NCD rollout in Tamil Nadu in today's session. And we have remotely connected to us, I hope, Dr. Frieden, are you with us? Dr. Frieden, are you able to hear us? Hi, this is Sanjay Mehendale. We have met a couple of times. Okay, so welcome to you on this particular panel discussion. We are towards the end of the day, and this is the last academic session that we are going to have on public health leadership and data utilization in decision making. So Dr. Frieden is a global leader in public health, as many of you might be aware, and he has done outstanding work in the areas of tuberculosis, tobacco control, and public health administration. He was posted in India for more than 10 years and was working very closely with RNTCP program. And that's where many of us come to know him and have worked with him as well. Currently, he is the president and CEO of Resolve to Save Lives. That's the organization primarily responsible for control of hypertension primarily and other cardiovascular diseases. Welcome, Tom. And what we are going to start with is, I'm going to request Dr. Frieden to make his presentation in the beginning. And then what we are going to do is we are going to start with our interaction with all the colleagues who are sitting on the dais. Does that suit you, Dr. Frieden? Okay, so we look forward to your talk, please.
Frieden, you are not audible. Just a minute. Frieden, you are not audible. Could you able to see the presentation, Frieden?
I can hear you. Can you hear me?
Yep, we can hear you, and your slides are on the screen now. So you may please start.
Great. Public health leadership and data-driven decision-making, this is crucially important. A good program uses data to improve performance. A great program uses real-time data to improve performance. And if I can have the next slide, public health is fundamentally a management problem. Management of three things: management of people, data, and context. Management of people means giving prompt feedback, building capacity, empowering people. Management of data to set priorities, monitor progress, adjust efforts, and evaluate effectiveness, and to manage and improve programs. What can be measured can be managed. And most challengingly, management of the context. That means the legal, media, social, and political context within which so many public health decisions get made. Next slide. There are three core areas for effective public health action: technical, operational, and political. All are essential for progress. If you'll click forward, technical rigor is extremely important. And an example of this is the vaccine for Haemophilus influenza. It's very effective. The technical side is so hard, so effective, that if we get to only 30 or 40% vaccination rates, we get a high level of control. If you'll click again, you'll see operational excellence. In here, I think of tuberculosis as crucially important. Tuberculosis is basically a management problem, making sure that every single patient is effectively managed and that diagnosis and case detection is done well. One more click shows political support, which is crucially important, and the example I use there is tobacco control. Tobacco control is really a reflection of the government's willingness to take on powerful interests in the interest of the health of their people. Next slide. This is the public health impact pyramid, the things that affect health. At the lowest level are socioeconomic factors. Above that are interventions that change the default values, such as smoke-free laws, 0 grams of trans fat, urban design, iodization of salt, banning of lead paint. One level above that are long-lasting protective interventions, such as immunization and smoking cessation and early life interventions, which may have a lifelong benefit. One level above that are clinical interventions, such as the control of blood pressure, cholesterol, and diabetes. And above that is health education. Generally, there is increased population impact at the lower levels of this pyramid and increased individual effort needed at the higher levels. Next slide. For that reason, for broader reasons. Generally, those at the bottom are more controversial and at the top are less controversial. And therefore, it's crucially important that we think about the social and political context of our actions, because there's a direct correlation, unfortunately, frequently, not always, but frequently, between how controversial an action is and how much public health benefit it will have. For all of these, public health leadership and data-driven decision-making is crucially important. Just to tell you one very brief story, when I suggested making all of New York City smoke-free to Mayor Bloomberg, this was an outlandish idea. It had not been done in any big city before outside of one state in the US, which was known as being very health conscious. And it seemed impossible. And the mayor asked me, was I certain it would save lives? And I said, yes, I was, because we had good enough data that we could make an estimate of how many fewer smokers there would be, and of those, how many fewer would die. So I could say with confidence that we could calculate that there would be approximately 11,000 fewer deaths if we passed this law. And that was a rallying cry. 11,000 lives were in the balance, and we got it through with great controversy. Next slide. After being a health commissioner for 8 years in New York City and running the US Centers for Disease Control and Prevention for 8 years, I summarized 10 things I wish I had learned at the very beginning of that tenure, and I'll outline them here. First, get good data. Data is the lifeblood of a program. The better data we have, the better decisions we can make, the better we can protect people and promote health. Prioritize and do the hard things first. There's a window of opportunity for action in public health, and that window closes. For example, in an elected administration, it may be early on. Or at this very moment, there's a window of opportunity to try to scale up public health capacity to prevent and fight epidemics because of the unprecedented threat of COVID-19, the novel coronavirus. 3, find and fight winnable battles. We don't want to address something that's going to succeed whether we do it or not. And I'm not very excited about tilting at windmills, but I do want to find the things that are on the balance. They're right on the edge. They might or might not succeed. And by our effort, we can help them succeed. 4th, hire great people and protect those people so they can do their jobs. This is the single most important thing we have to do. No matter how hard we work, no matter how smart we are, it's our team that's going to succeed, not us. And so we need to build a team. In public health, we have to address both communicable diseases and environmental health, or we won't be able to address anything else. It's very important to address those 2 things, but that's not the full range of things that we need to address. There are injuries and non-communicable diseases in particular, and it may be difficult for public health programs to really address injuries and non-communicable diseases because there's so much focus on outbreaks or environmental threats. 6th, don't cede the clinical realm. Don't give it up. There are some public health people who think clinical medicine is too complicated, controversial, and by the way, most of our advances in public health have been through things like fluoridation of water and chlorination of water and clean air, so we don't get engaged. But clinical care is extremely important, and it's a complement to public health action. That's why, for example, we're focused on scaling up hypertension treatment globally, and India is a big leader in this with terrific technical leadership from Dr. Pradeep Kaur and tremendous political leadership from the DG, Balram Bhargava. India has made a commitment to expand this program to every state in the country. This is terrific. There is no other country in the world that is moving forward as rapidly with the HEARTS program as India. And I was delighted to meet with Dr. Chakraborty in West Bengal and to travel there in the past year and to see the plans to do this well. 7th, learn the budget cycle. There's always a certain right time to make a request. It comes around each year. Sometimes there are unique opportunities because of a crisis. 8th, manage the context. It's very important that we manage the context. That may not be easy, but may mean working with media. It may mean providing very high impact graphics or information. It may mean identifying who the key decision makers are and who needs to say what. Right now, yesterday and today, I'm working intensively with the US Congress because I'm hopeful that in an appropriation bill that will go through tomorrow, we'll get resources to support global public health. Not we resolve to save lives, we the world. To do that, we have to figure out exactly who will be most effective to carry the message, what the most effective message will be, and who needs to hear that message. Ninth, never surprise your boss. This is very important. Doesn't mean you can't do things that your boss may not be entirely happy about, but it does mean that it's very important that they know the context more than you do. They have constraints that you're not aware of, so you have to keep them apprised of what's going on. And finally, follow these core principles. These are principles that were established at US CDC years back, and I found that they are wonderful and really keep you out of trouble and on the right path, whatever you do. First, to be a diligent steward of the funds entrusted to your agency, remembering this is money that was hard-earned by someone and you need to spend it responsibly. Second, provide an environment for intellectual and personal growth and integrity. Third, base all public health decisions on high quality data, openly and objectively derived. Fourth, place the benefits of society above the benefits to the institution. And fifth, treat all people with dignity, honesty, and respect. And if you follow these principles, you won't get very far afield. The final slide is a quotation from Peter Drucker, and important to remember in the context of data. The purpose of information is not knowledge, it is being able to take the right action. So thank you very much, and I'm sorry I wasn't able to join you there in person, and I look forward to this panel discussion.
Thank you, Dr. Frieden. I would like to just tell everybody over here is that although he's not here physically, Dr. Frieden is going to be listening to our program here. And if the audience, at the end of our session, we are going to have question and answers. So if people would like to have any specific question addressed to Dr. Frieden, he'll be very happy to take it as well. So thanks very much again, Dr. Frieden, and I hope you enjoy the session that follows now. We are now going to move on to the other panelists over here. See, the whole idea is let's try and discuss as many examples as possible, because we are discussing leadership, and people sitting here in the audience would be truly happy and they would be benefited by understanding how exactly the kind of capacity building that happened in case of all of you as participation in the applied epidemiology program or MPH program, how that really helped you to become a good public health leader. And I would request you to give a very specific example as to how this happened and how it helped you really, and so that the audience gets benefited appropriately. Yeah. Can we start with you, Dr. Chakraborty?
Thank you. Yes, see, leadership means many things. You will have to be excellent of many aspects. See, right, that your team members, you will have to know everyone, their weakness, their strength, you will have to know. Not only the teammates, but you have to be more careful about your own weakness and own strength. You will have to be very clear of that. And many of us doesn't actually realize these things, what is my weakness. But that will have to understand clearly so that you can be a successful leader. And you can influence others. Second thing is that, should I tell these things or just go to, because...
If you could give a very concrete example.
Yeah, that I'll do. Just overall some points I just want to tell. Because you see, background should be that relation with all the team member and the personal relationship that makes a very good success. Particularly, you see, with your subordinate, with your superior, and with the other multiple stakeholder at the leadership, you will be, but particularly the health leadership, you need to coordinate with many other sectors, people, and personal relationship really creates a magic. Then I'm telling some responsibility, authority, you'll have to donate that, you all know. The thing is that data analysis, that now you need your excellent skill in data analysis, in the computers-based skill, and then data analysis to derive the information and to generate the evidence and to apply this evidence into action. Now, with this background, now I am just telling a success story of mine, if I tell. You see, PPIUCD is one of the program which is a really good program, what I believe from my heart, because the contraceptive as a measure, IUCD is never for the all temporary measures, IUCD may be the best. Now, postpartum IUCD insertion was a technique, but normally the IUCD is acceptance very poor in our country, and it is only 1.5%, but not more than that as per the NFHS 4 survey. It is throughout the country. It is also in our state. And when I took the charge, but 2 years already lapsed that PPIUCD has been started, but our state couldn't progress anything. Tamil Nadu, we are just jealous about the Tamil Nadu, because Tamil Nadu was really doing very good thing. And I have just seen this data that in that year, 2017 most likely, 2016 or 17, then Tamil Nadu was around 22 to 23% of the total institutional delivery at the government institute. They are inserting the PPIUCD. So this is a really good thing, but our state only 4,000 is the absolute number. 10 crore population, and then 15 lakh is our delivery, of which 10.5 lakh are delivered in the public institute. So we have 10 lakh plus delivery, and we have only 4,000 PPIUCD in the year 2016. Then I took up the charge. I have analyzed this whole thing, that what is the constraint. The thing is that, so many things I have just analyzed. The first thing is that there are some incentives. So this is a very lucrative incentive, 150 rupees per insertion. So people will be interested. But you see, hardly any sister or doctors are interested to do these things, because you see, the fund is not being seen by them. The program is going on for 2 years, but fund is not reaching to them, because nobody has cared to give the fund. But this is the thing, I just picked this up, and I insisted that within 1 month, each month you will have to give the fund. And I can tell one district, that is Balurghat District Hospital, they have just done these things, that immediately every week they have given the fund, they have developed these things, and Balurghat going to very good pickup, took the pickup. This is only one issue. But the second issue is that the training was done by the medical college, because I understand that training, when the good training must have the very good impact in the program. The training there should not be haphazard way training, and that's why I just identified the medical college, very interested, young, motivated gynecologist. I have exposed them in the national level training. Then I create the pool of the trainers, and then I have given the TOT to the district level. But always I have picked up the best, most motivated gynecologists and young. So they, when the lead and when the cascading manner, they are training these in the district level. The training quality was very good up to the bottom level, and then this is a good motivation for the program. And particularly the other thing is that every time we are monitoring the progress of each district, then compare with each district, then a healthy competition has been developed, and then we have encouraged the leaders that who has done very well. So we are encouraging, giving some prize, boost up, motivation this way. So in the way, I am just telling, from 4,000, that year it came to 27,000 only. Next year it came to 2 lakh. Next year it came to 4 lakh, until it is now sustaining 4 lakh. But this 4 lakh is not at the cost of the IUCD. IUCD has come up from 60,000 to 2 lakh now. So 2 lakh plus 4 lakh is 6 lakh per annum. This is quite good, and this is still now the best in the country level. In the national level, this is the best performing. And the rate is now 39 to 40%. It's a 4 lakh out of 10 lakh. So it is 39 to 40% of the PPIUCD, and this is very, very appreciated by the country. So
Thank
this
you.
is a success
Yeah.
story. How
we,
I can
we must all clap for this. Excellent, excellent story, Dr. Chakraborty, because, and we do need to hear such kinds of stories. So, and there are several other questions for which I am going to ask you to narrate your stories and experiences. So I would really appreciate that. Please keep it brief if you can. Dr. Vidhya, would you like to share your story now?
Yes, sir. So, FETP training had helped me in analyzing and interpreting the data and asking the right questions and communicating with the higher-ups with the appropriate issues like the skills for communication. It has helped me to develop, and also reviewing the cadre below. So, I gained all these competencies after doing my MPH. And one example I would say is like as soon as I joined my directorate back after my MPH, I was in the section where we monitor the school health program, that is the Rashtriya Bal Swasthya Karyakram program. So as soon as I took charge, first thing which I worked extensively was on the searching for the denominator. We have program data like numbers screened. Actually, in the program we do screening of children for various diseases. So we have data like number screened, number referred, number treated, but where is the denominator? So the file which I extensively worked was to get the denominator from the education department on the number of school children in the schools, government and government aided schools, and number of children registered in ICDS and Anganwadi centers. So after that, I made interpretation. I analyzed the data which was available that time, and I was able to give a feedback to my higher up about the issues existing in the data capturing and data entry. So after that, we worked on the forming a reporting format, monthly reporting format, and which is now being used extensively across the state. And thanks.
Dr. Pradhan, would you like to share your story?
In my view, I always think that how much you can imagine. As a public health leader, you have to imagine a lot. If you have some evidence, you consolidate the evidence and imagine. And if you can imagine to the most height, then you can put down that imagination to action. That is my belief. So in that context, I have several experiences in the government system, because when you are in the government system, you are dealing with not only health department, you are dealing with the administration, bureaucrats and political leadership. And they have different agenda, and your agenda is different. So how to put your imagination to their imagination and catch them together so they will support you. Unless they support you, big work cannot be done. You will be doing a small work. In that context, I will give the last experience that we did in malaria control program. I have other experiences, but here I am saying, sometimes in the public health department, you will see that people will always hide data. But there is a problem, so you don't show the problem. I was going opposite in my direction. I was showing the problem, that this is the problem of Odisha. I was presenting to secretary, even to the minister and others, that this is the problem of Odisha. They are hearing patiently because I was giving the logic behind it. This is the problem. This is not, you are not responsible. It is responsible of the land. The land is malariogenic and you are not responsible. The data is clear and the problem is more. And with that context, I was advocating at the national and international level that this is the burden of Odisha and this needs support from national and international level. At that time, so that I was advocating for 2 years to get a huge quantity of long-lasting net. And I have gone to different platforms, even the international platform, to present the data of Odisha. So at that time, many other states, they are hiding the data and they are not able to project and they are not getting the support. So that was the first thing. I always say that don't hide, but say the truth. But say the truth in a manner that will not hurt the administration, that will not hurt the political leadership. That is the first thing. So in that context, at the same time, I was doing operational research in my own program setting with ICMR support, WHO support, and malaria medicine venture. They are supporting in that centers. Because they are testing, we wanted to test T3 at that time, because you are advocated by WHO, test, treat, and track. And by that, you can eliminate malaria. So that was the concept of T3. So with that, to test that, I was doing in the malaria in my different setting of Odisha, and I found that the whole agenda that we have put in the protocol is not really working, because it is working in the moderate, low to moderate transmission area, not in a high transmission area, in PF area. So I got a impression, and one data came to me very suddenly that there are afebrile cases. Means there is no fever, but malaria persistence is there in the hard to reach area, but the surveillance is poor. This has been in the literature, mentioned in the literature, but neither the national program nor the international program, they have defined that how to tackle this asymptomatic malaria. And at that time, one of my friend also, he was in NGO sector, he was doing some small research in a tribal area. He also came in the same finding, which my finding came up. So at that time I thought that how to, with malaria can be eliminated unless, if you can reach to the unaddressed people who are having herd immunity and they do not show any fever cases, but they have the malaria parasite in their blood. So these are the two things came to mind. So I put two concepts in my mind, that to control malaria in Odisha, in hard to reach tribal area, you have to clean the parasite from the population and you have to clean the anopheline vectors at the same time. That was my rider. So for that you need a huge quantity of feline and also mass screening to a huge population. This is not in the Government of India guideline. Who will support you? So for that, I had to take very, very definitely to my secretary. She knew that I am passionate for malaria. So she understood me very fully what I am saying. Then he said, you devise a proposal. So I devised a proposal. Then I said, Madam, this will not be accepted by Government of India. Nobody will accept me. Everybody will reject me. Everybody will criticize me. Then, because she had the confidence upon me, she said, health is a state subject. Go ahead. And state will support you. And I took 2 years to advocate at the finance department to get the support. So after 2 years, there is another context. There is another event happened in a very tribal area, in a hilltop area. Children died. And there I did this activity and the government appreciated. And suddenly the finance department said, okay, you go ahead for the whole state. Why are you confining to 8 districts? So the whole project was sanctioned for 5 years. And that was a really day when I was really jumped that my imagination could be, captured the imagination of the government to the administration. And at the same time, I am saying, Global Fund supported me with 1.13 crores of long-lasting nets, and it should have been come by January. It came in May, and it was really scorching sun and the humid climate followed by rainy season. I have to distribute the whole 1.13 crores of net within 4 months in 40,000 villages, and it was a huge task. So I have to take the confidence. I built an institution for that. A different committee from district level, from block level to district level to state level, even of the chief minister cabinet section. Because such a huge quantity of net may be spilled over, may be stolen, may be burnt, may be political crisis, many things will happen. So it was done starting from the CM's office to collector office, even the police department was involved, everybody was involved, and all the stakeholders, whoever available everywhere, they were pulled in. So that was really, I gave the imagination to the administration, I gave the imagination to the political leadership, that this will give a mileage to the political leadership for the next election. That was my internal message to them. If you get, and so no airline was distributed without flagging by a political leader. So all the political parties, they came to flag the distribution. So within 4 months, without any lacunae, I am saying 5% lacunae maybe, and it was distributed in 19 districts, 40,000 villages at one go. And the comment from external evaluation came that the distribution in Odisha airline is like an election campaign. So that was the comment. I thought in the assembly session there will be a lot of hola gala. No single question came in the assembly session. So that I said to my secretary, no single question in assembly session means it's a great success. And it is really the imagination that captured the imagination of many. And then I followed with Daman, this new concept tomorrow I will tell, how it came, how it was evidence-based, and government sanctioned the fund, and within 1 year, there is 80 to 90% reduction of malaria cases in Odisha, which is not, it was astounding. And I got a call in the midnight from WHO headquarters, Geneva, to come to Mozambique to the World Malaria Report event. I went there, and I addressed 10 African countries also with the concept only. And the concept is rolled now, and it is, tomorrow I will speak on what is the result. But this is a thing that I again say that, I don't know, there is an energy behind the imagination. And that energy becomes manifested when you are passionate around that and you drive around that. And that is why I think that is my public health spirit. Thank you.
Thank you. Thank you very much. Dr. Sharma, your experiences, please. Can you give an example, a good example?
Thank you, sir. In NI, we were taught how to look at data. We had the integrated disease surveillance program in place. But again, the reports which came hardly detected any outbreak. The reports were coming in a routine manner. In Alipurduar, which is endemic for malaria, we began getting daily data, fever data of fever cases, febrile cases, and got the samples tested. And the last 5 years, we have detected 7 outbreaks of malaria with no casualty. Huge numbers, every outbreak having more than 500. So this is where we felt, if you look at the data, the way it should be linked, and Dr. Tom Frieden was saying, live data, real-time data, not data after 1 month, the outbreak is over. That was very important. The other issue, data-based again, we took action. In West Bengal, in the municipal areas, we have a fortnightly house-to-house visit by volunteers looking for various larval indices, and wherever they are very high, vector control team gets into action. There's a place called Jaigaon at the Indo-Bhutan border. Well, that place has got lots of problems with sanitation and hygiene. That's an issue. So this program began. So as we were doing these works on a fortnightly basis, we found the larval indices were not coming down. Then at the district level, we could convince the district administration and the political leaders that we need to go for a weekly pulse cleaning drive. So every Monday, we had around 800 people mobilized using local resources. We got down to doing this pulse cleaning drive, house-to-house visits, clearing all the containers, scrubbing them dry. There was lots of resistance, political and otherwise too, but we persisted. And in 6 weeks, we could bring the dengue incidence down, and I have an oral presentation day after tomorrow. 2014, Jalpaiguri Alipurduar has huge outbreak of Japanese encephalitis. There was an issue, and our ex-DHS, Dr. Satpathy sir, had come to Jalpaiguri, and he asked me, Puran, what can be done? And I said, sir, the situation is very grave, I don't know, but I have heard that there's a study going on with adult JE vaccination in Dibrugarh. I am not sure whether the trial is over or not. If we could, I called Dr. Murhekar, sir. He said, Dr. Gupte must be having, Professor Gupte. I called, sir. And sir immediately shared the document with me, the Dibrugarh ICMR report, which I shared with my Director of Health Services. And in 3 months' time, we had sanction for adult JE vaccination. Because what we were seeing was, there was an age shift. In 2013, we had vaccinated children, 0 to 15 years of age group. Now there was an age shift. So it was more in the adult age group. And that we could do. And now the incidence of JE is very less in Jalpaiguri and Alipurduar districts, and it is being done in other districts of West Bengal as well. Thank you.
Thank you very much. Dr. Vidhya, NCD rollout program in Tamil Nadu was one of the first ones, right? We would like to know from you exactly what the status of the program is right now. Have you been able to identify any gaps in particular? And have there been any specific attempts to bridge those gaps? Because why this is important is many other states where similar kinds of problems possibly exist, these could be good guidance points that we could have. And if you could also make some kind of points on intersectoral collaboration on this. Because there is always a big amount of interest in this intersectoral collaboration. As a concept, it looks so very attractive, but when you come to really down to earth and try to approach various other sections to cooperate with you, you do not necessarily get the kind of cooperation you need. So what kind of efforts you did in that direction, and did you get good response? So will you like to talk about that?
Sure. So NCD program in Tamil Nadu, so it weighs back to 2007, during which piloting was done, and from 2010 the program was upscaled across the state in phased manner. And this is ahead of the national program NPCTCS. And now it is being implemented in 1,800 plus facilities. And in addition to that facility-based screening, we have expanded the program like with the components like population-based screening, daycare chemotherapy centers, district pathology centers, palliative care, and etc. So the key elements which helped us to implement such a mass program pertaining to our state were like we had political commitment, external funding from World Bank. In addition to that, state government was also committed and spending, meticulous planning by the project team at the state level, and implementation was done through the public health system. And we had leadership even at the district level and even at the block level, and concurrent evaluation done by NIE. Of course, this helped us to use the data, real-time monitoring, and give effective feedback during the initial phases of implementation, and training and supportive supervision, and consistency in commitment even after the transition of the program from World Bank funded to the directorates. And also we have consistent supply of drugs. So all these elements helped us to implement the program in a, I could say, successful way. And now what are the gaps I feel is, though we were doing the program more than a decade, certain gaps like we have, as we do in MPH, like the program evaluation, all the inputs are exactly there and all the processes are happening, but the processes are not monitored consistently. And so the outputs, we have some deviations. We are not getting the expected outputs, or we cannot show the expected outputs. Though we get the outputs, but we could not show to the world that how much we have achieved. So the gaps, I would say, would be like this monitoring needs to be strengthened, and we have to, though we have supportive supervision team, it has to be consistently provided and should be improved. And the referral pathway, actually after screening, we have this program happening across the levels of facilities. Like primary, it starts from screening and ends with the treatment and management of complications. So the referral pathway should be improved. And also one more thing is this NCD is still viewed as a vertical program by some of the stakeholders, and still it is not becoming as a part of routine review. So these are the basic gaps which I feel now it has to be focused on to further take up the program to a good level.
I think this whole initiative was initially taken through TNHSP, right?
Yes,
Tamil Nadu Health System Project.
Yes.
But it's really heartening that there is already discussion happening about Tamil Nadu Health Reforms Project now, which is going to be phase 2 of this project. This just talks about the good work that has been done by the government of Tamil Nadu. So congratulations for the work that you have initiated, and certainly for showing us all the path that we can take over a period of time.
Thanks.
Yeah. I would like to ask request you, Dr. Chakraborty. See, like there are quite a few young people sitting here in the audience here. So for them to be good public health leaders like you, what kind of important messages would you like to give them?
Basically, you'll have to understand the situation analysis that I have learned from Chennai, that is NIE, Chennai. That first task is that to understand the situation. That situation analysis critically is a very important role. And just I'm sharing another success story, that IMI in North 24 Parganas district. That district is peculiar because that district has around 1 crore population, and the 50% is urban population. There are 28 municipalities, and all are run by the local self-government, and they never listen to you. So everybody is living in his own kingdom, and the immunization is very horrible condition is there, And the overall, only one district has been identified at that time for the 100 districts among the country, only one district from our state, that is the North 24 Parganas, for the poor performance of the immunization. And the immunization rate is overall 80% at that time. In our state, it is a very low, we consider. Our state, around 90% is the immunization stat. Now, that is very near to Calcutta, that is adjacent to Calcutta, then why this so weak immunization rate? Then I went to the field. The initial first round, it was only 4,000 was the vaccination. Only 4,000 children were vaccinated. Then I have just gone there and understand that what are the problem there. Problem is that the urban body, they are now motivated, but think that they don't have the recipe with their hand. They don't understand that what is their exactly action to do, because there is no continuity of the program. Because you see, in the rural area, we have a robust health system. Now everybody is learned from his superior, senior, that what is going on. So how to plan, how to execute the plan, that is there. But here, every officer, he is something inventing. There is no parampara. So that's why I understand these things. And when I understand, in the next round, I just bring some DPH, good senior public health nurse from the block. I tell, okay, block, I'll compromise in the block for the time being, that put them in the urban area, and for every municipality, I give one senior PHN and keep them full empowerment. I encourage them, make a short WhatsApp group. I every day create a good interest, and give the vehicle support, give them very high honor. So they are in charge, and I told that you are the king, you are the queen, and through you we will just change the urban scenery. And you can't believe, after the full exercise, the next round it was 10,500 vaccination, and then it goes to 15,000, 20,000 in this way. Now after this 4 round, UNICEF has independently, through the government of India, has given the task to assess the vaccination status, and that was 97.5%, full immunization status, from 80%. In an urban setup, it is a tremendous success, I can believe, but that is because only 2 things I can tell, that exactly I understand the situation going in the field. Without going to the field, I can't get these things. I can't get these things, that why the people are giving the vaccine, but till the vaccination is not taking up, because they don't know how to do these things. And then, the pulling up the good people, entrusting them, giving them full power, and encouraging them, and continuously monitoring them, give their success story, sharing with among the group, this actually boost up, and everybody tried to show her best, excellent. So I could extract the best from everybody, and that's why the success. So I'll just encourage everybody, just see, you give your best, but you extract your best, and if you can extract your best, you will be the good leader, best leader.
Thank you very much. A similar question to you, sir. So you are going to give a talk on malaria, so I will not ask you any more questions on malaria, because that would be kind of duplication. And so I leave it to you to discuss malaria in your next talk. But essentially, any messages that you would like to give to youngsters as to perform better and to be good leaders?
The basic questions, I always say that you should know to ask yourself, what is the problem? And for public health action, you do not need to do a very big primary study. The secondary data is enough to give you a glimpse that what is the problem. And around the problem, you think, and then see how the problem can be solved, who will be helping you. There is no enemy in the public health. If you feel that somebody is the enemy, then you are gone. Please see that nobody is the enemy. The enemy can be befriended for your action. That is one message. And who are the other stakeholders who are really can be helpful, but they are not on your net now. So bring all those stakeholders to your net. Then you can do the imagination that what is the problem and what is the solution and who will be helping you. Never think that you can do. You alone cannot do in public health. It's a huge dimension. So don't think that you become a leader, not a declared leader, but think that you are the leader who can engage many stakeholders for the work, for the problem to be solved the right direction. It may be from a politician, it may be administrator, It may be health department, WC department, tribal department, forest department, even the NGOs in the private sector, whoever. So how to rope in everybody for the problem you are thinking that they can be solved by others. And for that you need a leadership quality. It is not an authoritative quality. I always advise all public health people should not be authoritative. They should be leaders. Leaders are polite leaders. They should not be authoritative. If you become authoritative, you are lost. Many friends will be enemy. So to make enemies friends needs leadership quality. That cannot, nobody can teach you. Be natural in the nature. Nature will teach you. That I always believe. I go to nature, I speak to nature, sometimes I write poems for that also. And it becomes an outfit of my work. I publish books also. So be natural on that way. Thank you.
Dr. Sharma, we heard that you encountered a situation when out of the blue you suddenly were given a responsibility to set up the health systems of a newly created district. I think the audience would be very benefited if you could share your experiences of how you managed to do this, and also focusing on the kind of problems that you encountered and the solutions that you thought of.
Thank you, sir. Well, I have my Director of Health Services in the panel, but I need to speak the truth. So I wasn't the Director of Health Services then. 2015, February, I got an order promoted as CMO of a new district, carved out of Jalpaiguri district. I was promoted, but I didn't know where I had to function from. I was given no office. I didn't know where I was to officially run my office from. There were no staff earmarked for the CMOH. So I asked the Chief Medical Officer then of Jalpaiguri if he could let me use your vehicle. So I went to Alipurduar, and the Assistant Chief Medical Officer of Health, who I knew before, I went to his office and I said, can you at least provide me a room? I said, so why not? So I'll leave my room for you. So he was very kind enough to vacate that room. I didn't have any staff to support me. So again, I had to do some, marketing, and enticed my juniors to provide me some clerks, 1 or 2 data entry operators. Some people even loaned stationaries to me. The tragedy is, the district was carved, the liabilities were shared, the assets were not shared. And no fund was provided from the state government then. It was not provided to us. So that is how the whole thing began. And Alipurduar, being a very remote district of West Bengal, highly forested, very difficult terrain, 40% tribal population, 63 tea gardens, for malaria and other vector-borne diseases, and a very high maternal mortality rate, a ratio of 202 per 1,000 live births. That was the challenge which we faced. But then I had to rope in my juniors, the BMOHs, the ACMOH, the data entry operators. So we worked from morning 10 till as late as 9. Sir has been witness to that situation in Alipurduar. We've worked like that for 3 years, and gradually we started getting staff appointed from the state, and we began to work. So they saw the leader of the district working. So they sat back, they never asked me, sir, can we go home? Because I was not leaving the office, so they stayed back with me. We arranged for minor refreshment. This is how the challenges were. And whatever I had learned during my public health practice from 2004, my learnings from NIE and from the seniors, we shared with the staff. They did lots of multitasking. So even non-medical people were doing medical work, they're analyzing data. I was sitting in their chair and doing the analysis work for them and guiding them how they should be analyzing data and putting forth things to the respective BMHs. This is how things began. And as I said, I had barged into someone's office and taken a room. Then we rented a premises. Now we have got a 4-story building ready. We'll be shifting very soon to the new office. Good new setup, and I believe in many parameters, Alipurduar is doing much better than many other well-established revenue districts. I believe my DHS sir will vouch to that. That's it.
That's a real nice story to hear. What we would like to do now is ask you all about one particular aspect is this, that we all know that there is, many people say a lot of data is already sitting out there, but we don't look at it. the lot of learning could actually come by effective utilization of available data rather than trying to generate new data. Do you believe in this? And are there any examples of, say, good utilization of such sitting data that you had in your own state, which was made actually explode in a beneficial way and which helped in eventual policy formulation of any kind?
Yes, definitely. A lot of data are there, and the data are really not that much analyzed, and data should be seen from the different angle, what I believe personally. That data normally analyzed in a monthly, and they normally has a monthly format, so that data come in that way, the data analyzed in this way, and they're showing some bar diagram. That is the usual picture in the routine analysis, but that doesn't help much. That is already everybody knows. But to see the data from the different angle is the real challenge, because the capacity is not available with everybody. So that is very important thing, how to understand this data. So that also I can just share one example with these things, so that this may not be exactly public health, but also public health means you will have to deal with the money, deal with the people, and deal with the materials. So when I joined as a CMOH in Murshidabad district, there a lot of problem was there because of the manipulated bill of the Nishchayan. That is the Matriyan, that is the carrying the free transport for the mothers and child. And there's a lot of inflated bill. And then with the lot of data was there, then I used this data. I just told every operator that in my Excel format, you will have to tell give the data, so that everybody, every day movement I can just see. Then from that, I just pick up to the AP info, what I learned from here, Chennai. From the AP info, you can just immediately pick up that one vehicle is showing 700 kilometer travel in a day. So this is not literally possible, particularly in the road condition, and also drop back the home and collect these things. Then with this data, showing the bar diagram, I just pull the people, the leaders of the Nishayan association also, to bring them in my table, show these things, and then tell that you explain me that how it is possible. Then showing this example, this type of example, I cut down their demand, and then also I just forced them, and they accepted these things, to utilize the GPS-based monitoring system, and they play the GPS in the vehicle. The thing is that how to utilize this data. And another example I'm just telling, that the ASHA also, when I just joined there, I have seen that ASHA, they have just claimed, normally ASHA claims would be 3,000 to 4,000 per month by the person, incentive-based remuneration. But that ASHA was demanding 7,000, 8,000, sometimes 12,000, and that's why the whole salary was, the remuneration of ASHA was stopped by the state order, that is for 4 months. And that time when I joined, then Eid was there. And in my district, there is a Muslim district, so Eid is a very famous festival. And for that, 4 months they are not getting anything, so there is a hue and cry in this way. But nobody can give the salary because there is a guidance from the state that you cannot be, still we just judge these things. Then I talked to the state people. Then I convinced them. Then before this, I just gave immediately 2,000 each to the ASHA. I told with the state people, getting them confidence that I will adjust these things from the later on, but let me just specify their demand. Now, after this 2 months, I have given this 2,000, but by that time I have analyzed these things whole. I have developed one program with the AP Info, so that the whole ASHA data, that whatever they claim, that comes to me, and I just run the program. Within 5 seconds to 10 seconds, it just generates that these claims are not regular because of some cutoff value was added to these things. The program, I'm just using a program, but the cutoff value was added to this, so that everybody, for this also you will have to inquire that how many delivery was there. Because you see, sometimes they are showing 2 delivery, and they are telling 3 or 4 night stay in the hospital. But the night stay is tagged with the delivery. So this discrepancy can be picked up immediately. But you see, I have 4,500 ASHA, and you see, last 8 months data I am just analyzing. So this is a huge lux of data. But through the AP Info, because I have learned it from here, I could easily analyze these things with the programming. And then is a lot of things. So every BMO send me the data. Immediately, the data can tell that this 10 ASHA can be given full payment. This 5 ASHA you will have to query for these questions. This 20 ASHA you will have to put this question. And in this way, immediately this thing was resolved. And these ASHA leaders also, I tell them across the table, show them the data, show them the birth diagram, and then just ask them, then you tell me that how 2 mothers you have, and how you can spend night with 5 mothers. So then immediately they decline, and they just, then this is a lot of public chaos could not be averted, and the settlement was there, and everything was smooth. So I'm telling you, there are 2 success stories. One is the Nishchoyan, there's a manipulation of the data was lost, and also this is manipulating a system, and also payment also a huge number was, that was no resolvement was there, because I have used this data from a different angle, show them, take their confidence, and convince them that this is the right thing, and these people can know that what they are looking, that hiding these things. So this is the success story I can tell.
Thank you very much. Dr. Vidhya, do you have any experience in this regard which you would like to share?
Not exactly the same way, sir, but I wanted to comment on data-driven decision-making. Like most of the times we program managers, many times we do decisions based on the programmatic observations, based on our field visit, based on the feedback we get, not on the actual data. And that has to be, doing so will not be a systematic way, and also it is not consistent. The direct observations will not be a consistent one. So any actions definitely should go as a data-driven one. And in that case, we need to have, as sir said, he was able to do the analysis because of this training and all. So we have to, empower our public health managers, even at sub-district level, to handle the data and interpret the data, so that it can happen at the facility level, which could be a data-driven decision making.
Thank you. Dr. Pradhan, would you like to share any experiences in this area of utilization of data, effective utilization of data, and which eventually helped in policy making?
Yeah. I just, there are several instances where the data helped to change the decisions and take action in a very big manner. I am just giving one example of my previous, during FETP, around FETP, at that time also. Just, I was picked up from that program to a FETP course. It was Super Cyclone 99 in Odisha, where 10 to 20,000 people died, and the coastal belt was devastated. And there was a lot of apprehension that there will be waterborne diseases and vector-borne diseases. And at that time, I was just a small officer in the government, and just working for the disaster management with a civil society organization and bridging the government machinery. And at that time, MSF, the Medicine Sans Frontier, and WHO, they came forward and they discussed with me, and we set up the surveillance system, post-disaster surveillance system, that is called multi-disease surveillance system, and which is the initiation for the IDSP in the country. So that experience was taken to Gujarat, that experience was taken to other states, and I was called by WHO to give my experience to them, and then IDSP was really floated at that time. And at that time there was no mobile phones, and there was no email communication is very poor. It was the fax machine which was doing the electronic work. So we have a format, and from which that we are getting the data from different districts from sub-center level. And certainly with that data, really we analyze, I was going through the data very carefully, what is happening each week. It is a weekly surveillance system. And I found that in some places there are measles cases. And that really helped me to that there may be a measles outbreak. So immediately I could, with that data, talk to government and talk to UNICEF and many other places who really suddenly they were jumped up with this data, seeing that. So they went to validate the data in the different field, and they found this is true. A measles outbreak is coming up, and suddenly UNICEF could come up to support for funding, and government machinery worked, and a ring immunization was done in 12 districts. And it was, then the whole outbreak was really averted. And that really gave me a lot of energy, that to data is so much, has so much energy. And when I entered to, because from that surveillance system, Dr. Gupta picked me up for the FETP course. And when I entered here, first thing they are teaching me data. So that really, and there are a lot, then I have a lot of, with data and leadership that I can speak a lot.
Okay.
But this is a first experience before around my FETP course.
Thank you very much. We are now closing the session as far as the presentations and panelists are concerned, and going to open it for comments and questions. But before we do that, Dr. Frieden, you have been listening to what has been happening so far, and you must have heard comments of everybody here. Before we open the session to questions and discussion, would you like to make any additional comments on what was discussed so far?
I would just congratulate all of the panelists on both the work that they've done and the clarity of presentation, showing that data really can save lives. And I was just reflecting on your question of an example of where data changed policy. And when I was health commissioner in New York City, we had implemented a tobacco tax and seen a big decrease in smoking. And then we had made the whole city smoke-free. We'd seen another big decrease in smoking rates. And actually we thought we were done. We thought our work was completely finished. But we had a surveillance system in place and it tracked the rate of smoking each year. And the next year, smoking rates didn't continue to go down. In fact, they slightly went up. So we realized that we couldn't just rest, we had to do more. And we looked at what did the data show, and the data showed that hard-hitting ads would make a really big difference. So we ran hard-hitting ads, basically quite expensive, but very powerful ads showing the harms that tobacco did. And then we saw the decrease continue again. So it's an example of if you have a surveillance system in place, you can adjust your program and improve it. And that's really the mark of a good program. I used to tell the staff in the TB program, the consultants, that the single most important thing they could do was to help the local areas they worked with look at their data and use their data to improve performance. Because no program is perfect. But if the staff themselves are looking at the data and thinking about how to use their creativity to improve it, then you can get a continuous improvement approach. So back over to you.
Thank you very much, Dr. Frieden. We are coming to the close of this particular interesting session. We started talking with data initially, and basically everybody, the take-home message that we have now is data is important only when it is actionable or performance-oriented. That's the basic thing we learned. It has to be really, one more important thing which came up is we must have the courage to project the right kind of data. Probably it also helps rather than hiding the data. That was a good message that we got here.
Just I want to add one thing just.
Sure, please.
Because you see, the data, so huge data is coming, and the quality of the data is not assured. But I'm just requesting you all to just monitor the data. Whatever the data you are getting, at least you see the data, you monitor the data, give the feedback. Unless you monitor the data, quality will not be improved. So to maintain the good quality of data, you'll have to see the data and to give the feedback.
Thank you. So in addition to data, we also talked about leadership, and we heard a lot of good examples of how vision was important, how passion was important, how perseverance was important, how dialogue was important, how team interaction was important, how taking along people was important. I suppose these are all the qualities of good leaders, and good leaders probably to some extent they are born, that's okay. But we all can be good leaders if we learn the right kind of way to move forward. I suppose that's something which we can all understand and try to be good leaders, because the country is expecting a lot from all of us. So thank you very much for joining us here. I would like to thank all the panelists for their excellent experience sharing, and also the audience for making this very interesting through good questions and inputs. Thank you very much.